When do you want me to start, Raghu?
Start பண்ணலாம் மேம்.
Start பண்ணிடலாம். Okay. Good evening, all. Welcome to this INICET quick recap of anatomy, right? Okay, so today you received the new regulations in INICET, yeah? So you have to be more conscious with time management. The visibility time is being reduced, divided into 4 sessions. So make sure you will not have time to go back and recheck or change your answers. Okay, so need not panic much over it. Okay, because yeah, uh, you know that previous questions will be asked, and once you read that question, make sure you're thorough with it. Okay, you can read it twice, but you may not have time to go back to it again. Okay, so need not panic over it. I'm sure you'll be able to manage it enough. Now, going to today's session in anatomy, as far as possible, we'll try to cover the most important topics in the following regions. So the questions, it can be a case scenario, an image-based question, and the multiple options. It can be an extended matching, sequential arrangement, and so on. Whatever it is, you'll be able to do it good. And the reason INICET most of them, the questions are very simple, direct questions, image-based questions. Okay. Hopefully, the upcoming one, yes, definitely you'll be able to make it. So we'll start with this question. Yeah, you're with me. So as you see here, 1 second. Some problem. Just give me a minute trying to sort out what is the problem. Raghu? Yeah.
Yes, ma'am.
Yeah, sorry, Raghu. I think I have some problem.
No problem, ma'am. No problem.
So we'll start with the first question in this session. It was recently asked, right? Arrange the following from lateral to medial according to the structures present in the floor of fourth ventricle. Like functional columns is a very, very, very important high yield topic. Luckily, you won't be getting the same question, but you should know related to this topic, isn't it? Yeah, anything, everything related to functional column is very important. It can be asked in a different, the question can be put in a different way. And I'm here to simplify it to the best of my ability. So we'll start. Okay. So imagine this to be the midline. Yes. So, right and left, we have the two columns. Efferent column comes first and then the afferent column. What lies between the efferent and afferent column? We have the sulcus limitans. The sulcus limitans. Okay. So medial to the sulcus limitans is going to be the efferent column and lateral to it is going to be the afferent column. How many columns are there in the efferent motor? We have 3, right? And afferent, 1, 2, 3, 4. Yes, very easy, right? So, the efferent and afferent, motor and sensory. Just be with me as I do this. What comes first and what comes next? The visceral column comes first, which means that it comes closer to the sulcus limitans, followed by the somatic. And then we have the general and special, right? Of which general comes first, followed by the special. So what do I have close to the sulcus limitans? The visceral and general. Okay. So this is going to be general visceral efferent. This will be general visceral afferent. Again, also we have the visceral columns, but we have the special, isn't it? Special visceral efferent, special visceral afferent, right? And then here we have the somatic next, general somatic efferent. Okay. Here we have the, yes, somatic, general somatic afferent, special somatic afferent. Just remember, efferent motor column is medial and the sensory column is lateral, right? And closer to the sulcus limitans will be the visceral column, 2 visceral, right? Visceral, general first and then special. So general visceral efferent, special visceral efferent, and most medial will be general somatic efferent, right? Okay, if you go through it again, definitely you will master this. Now, how to remember a simplified, okay? The cranial nerves related to each column. Lot of MCQs are related to this topic. Just be with me. Another 2 to 3 minutes, we'll finish off this topic, okay? So as you see here, as I told you, the most medial column is general somatic efferent, special visceral efferent next, and then general visceral efferent. Yes. So general somatic efferent, if you remember this small smiley icon, it's enough. What is prominent here? What are the cranial nerves which come under this? The cranial nerve which innervates your eyeball, 3, 4, 6, and the cranial nerve that's going to innervate the muscles of the tongue, isn't it? Motor nucleus. All these are going to be derived from the somites, mesenchyme, mesoderm of the thoracial mesoderm, the somites. Okay. So sixth nerve, what muscle does it supply? You can enter in the chat box, right? Lateral rectus. And fourth nerve, superior oblique. Third cranial nerve, it supplies levator, palpebrae, superioris, superior rectus, medial rectus, inferior oblique. Yes. And then what about the 12th nerve? It supplies all the muscles of tongue except, who's going to tell me? Except palatoglossus. What do you mean by special visceral efferent column? Okay. The nerves which are going to supply the muscles derived from the pharyngeal arches. So you can easily remember it using this. Yeah. Nerve of the first arch, mandibular nerve. Second arch, facial nerve. Third, glossopharyngeal nerve. Fourth, vagus. And sixth, recurrent laryngeal nerve. The cranial part of the accessory nerve we can include here. Yeah. How to remember the muscles innervated by the mandibular nerve? Totally 8. We can divide it into 4 plus 2 plus 2. What are the 4 muscles? 4 muscles of mastication. What are they? Masseter, temporalis, medial pterygoid, lateral pterygoid. And the 2 tensors. What are the 2 tensors you know? The tensor tympani, tensor palatini. And yes, 2 more. Who's going to tell me? Anterior belly of digastric, mylohyoid. Okay, 8 muscles, 4 plus 2 plus 2. Right. Facial nerve, 7th nerve, you can remember it as 7 muscles. Muscles of face, muscles of scalp, muscle of auricle, the muscle of the neck, the subcutaneous muscle of the neck, platysma, 4 plus 3. What are they? Within the ear, stapedius, and then I call it as the SPB muscle. Yeah, stylohyoid and the posterior belly of digastric. Okay, 7 muscles by the 7th cranial nerve. Glossopharyngeal nerve supplies the stylopharyngeal. The external laryngeal branch of vagus innervates the cricothyroid. Yes, what is the action of cricothyroid on the vocal cord? It's a tensor. Injury to the external laryngeal nerve, the patient is going to present with a weak husky voice, right? And the cranial part of the accessory nerve, muscles of the soft palate, pharynx. Recurrent laryngeal nerve is going to supply all the muscles of the larynx except cricothyroid, right? So this is all about the special visceral efferent column. Done? Yeah, 5, 7, 9, 10. 5, 7, 9, 10. Coming to general visceral efferent, which means that they are going to be related to the parasympathetic component. Yes, tip of your fingers, can you tell me what are those nerves? 3, 7, 9, and 10. What is the parasympathetic nucleus of the third cranial nerve? Edinger-Westphal nucleus. What is a ganglia related? Ciliary ganglia. What are they going to do? The parasympathetic component is going to innervate the sphincter pupillae and one more muscle, the muscle of accommodation, ciliaris, isn't it? Right? Okay. And parasympathetic nucleus of the 7th cranial nerve, 2. What are they? Superior salivatory nucleus and lacrimatory nucleus. The superior salivatory nucleus is going to innervate the submandibular and sublingual ganglia through which submandibular ganglia, right? Similarly, the lacrimatory nucleus through the pterygopalatine ganglia is going to innervate the lacrimal gland. What is the parasympathetic nucleus of the glossopharyngeal nerve? Inferior salivatory nucleus. Yes, for which salivary gland? Parotid. Okay. The inferior salivatory nucleus is for the parotid. Superior salivatory nucleus is for the submandibular and sublingual. Okay. Coming to the 10th nerve, yeah, parasympathetic, the dorsal nucleus of vagus. Right. Now, what is nucleus ambiguous? I didn't tell you, right? So, this special visceral efferent column, the 9, 10, 11 cranial nerves, they all arise from the nucleus ambiguous. Okay. Now, easy. Coming to the afferent columns, general visceral afferent, right? General visceral afferent, special visceral afferent, general somatic afferent. General visceral afferent, you can just remember the nerves innervating the carotid body and carotid sinus. What about the special visceral afferent? Taste sensation from the tongue, right? You know that the taste sensation from the posterior most part of the tongue, what is this area called? Vallicula, right? General and taste sensation is by the vagus nerve. And the posterior 1/3 of the tongue along with the circumvallate papilla. General and taste sensation is by the ninth nerve. Special visceral afferent from the anterior two-third of the tongue. What is the papilla you have there in the anterior two-third with the taste buds? Yes, from the fungiform and the foliate papillae. The filiform doesn't have taste buds, right? From the fungiform and the foliate papillae, chorda tympani branch of the seventh nerve. Whereas the general sensation is carried by the lingual branch of mandibular division of trigeminal nerve. So under special visceral afferent, we have to write 7, 9, 10. What is the nucleus here? Nucleus tractus solitarius. Fine. Coming to the general somatic afferent, it's about the sensation carried by the over the face. And that's the territory of the trigeminal nerve. What are the three divisions of the trigeminal nerve? Ophthalmic, maxillary, mandible. The tip of the nose, please appreciate from the diagram, is from the ophthalmic. Sides is from the maxillary. Upper lip is from the maxillary, whereas the lower lip is from the mandibular. And more important, the skin over the parotid, the skin over the angle of the mandible, where the people like they shave the beard, all that area, okay, is innervated from the cervical plexus via the great auricular nerve. Okay, so please remember that's not the territory of the trigeminal nerve. And what is the cutaneous, only cutaneous branch of the vagus? The Alderman's nerve, the Arnold's nerve, which supplies the concha of the auricle. During syringing procedures, the patient can go for bradycardia, right, due to stimulation of this nerve. Okay, so that also has this general somatic afferent, right? And that has communications with the seventh nerve, that part. And part of the ninth nerve, the general sensation from the pharynx, from the tonsil, that also is included here, they included. It all comes under general somatic afferent. Okay, so this diagram will do it. General somatic efferent, special visceral efferent, general visceral efferent, general visceral afferent, special visceral afferent, general somatic afferent. So if you remember just one image, it's going to be easy. Yes, 3, 4, 6, 12. 5, 7, 9, 10. 3, 7, 9, 10. This is going to be 9 and 10. 7, 9, 10. 5, 7, 9, 10. Easy. Okay? Yeah, you will be mastering this topic if simplified. Now, the year before, like last year, right? They've asked about internal capsule. Neuroanatomy, the high yield topics, please remember, it's the spinal cord. You should know the ascending, descending tract, where it is located, arrangement of fibers in the spinal cord, the brainstem syndromes, everything about cerebellum, cerebrum, blood supply, internal capsule, the white matter, basal ganglia, right? Fornix and mammillary body. These are the favorite questions in the neuroanatomy part, right? So what are the things you're expected to know about internal capsule? You should be able to identify it in the image, right? You should know the parts of the internal capsule, the arrangement of the fibers, especially the motor fibers, blood supply. Okay. So this is the horizontal section of the brain. Yeah, corpus callosum. You can make out the anterior horn of the lateral ventricle, posterior horn of the lateral ventricle. In the floor of the anterior horn of the lateral ventricle, this gray matter that you see here is the caudate nucleus. You can see the septum pellucidum and the fornix, right? Okay, this is the region of the third ventricle. Either side of the third ventricle, the gray matter that you see here will be the thalamus. You can make out the lentiform nucleus, right? The outer putamen and inner globus pallidus. So where is the internal capsule now? This is the internal capsule. What are the parts of the internal capsule? It has the anterior limb, posterior limb, genu, and the retrolentiform and sublentiform part. Through the sublentiform part, auditory radiation passes through. Through the retrolentiform part, optic radiation will pass through. And coming to the more important point, through the genu. What passes through the genu is the corticonuclear fibers for the head and neck. So any lesion of the genu, paralysis of the muscles of the face, head and neck, right? Yeah. And posterior limb is much more important. It has the pyramidal and the extrapyramidal fibers, the corticospinal fibers for the rest of the body, upper limb, trunk, and lower limb. We'll discuss and come back to the question again, right? Okay. So this is again coronal section. You can make out the internal capsule here, right? So here, this is the anterior limb. Okay. And this is the, I'll take a different color, highlighter. This is going to be the genu, right? And then here we have the posterior limb. Yes. And then I'll mark it as the retrolentiform part and sublentiform part. Coming to the blood supply of internal capsule, the upper part of the anterior limb, genu, and the posterior limb is going to be supplied by the middle cerebral artery. Occlusion of the middle cerebral artery can affect the anterior limb, the genu where we have the corticonuclear fibers for the head and neck, and the posterior limb which has the fibers for the rest of the body, right? So middle cerebral artery, major blood supply to the internal capsule. Apart from that, you should know that the lower one-third of the anterior limb is going to be supplied by the anterior cerebral artery. The lower one-third of the genu has direct branches from internal carotid artery from the posterior communicating artery. Okay. The lower part of the posterior limb, the retrolentiform, sublentiform part is going to be supplied mainly by the anterior choroid artery, which is again a branch from the internal carotid. Now, two named arteries, Charcot's artery and the recurrent artery of Huebner. What are they branches of? The Charcot's artery of cerebral hemorrhage. Their thin-walled vessel, a rise in blood pressure can rupture it. Okay. And it's a branch from the middle cerebral artery. Whereas the recurrent artery of Huebner is a branch from the anterior cerebral artery. So this is all about internal capsule. Okay. Now, correct statements about the internal capsule. What are all the correct statements? Charcot's artery supply posterior limb. Yes or no? It's a branch of middle cerebral, right? So yes. Retrolenticular part contains optic radiation. Yes. Anterior limb has corticospinal fibers? No. Right? The corticonuclear fibers for the face, head and neck will be in the genu. Upper limb will be in the posterior limb. Of course, internal capsule is a projection fiber. As I told you, it's going to come from different parts, like from the frontal, parietal, temporal, occipital lobe, right? That's called the corona radiata. It's going to continue as the internal capsule and then crus cerebri of the midbrain, right? So those are all the correct statements. Okay. Now, moving on to the next question. Yes. What is the arrow pointing at? The following structure projects into which thalamic nucleus? So you're supposed to identify it. As I told you, fornix and mammillary body, they keep asking again and again. You can identify the corpus callosum here, right? This is the rostrum. This is genu. This is the body. And this is the splenium of corpus callosum. Can you see the septum pellucidum here, right? And where is the fornix here? Who's going to tell me? Can you identify the fornix? Yes. This is the fornix. Where is the fornix going to come from? Fornix is going to come from the hippocampus, right? And it's going to end, it's a white matter fiber coming and ending over the mammillary body. This is the region of thalamus. This is the hypothalamus. The one pointer here is the mammillary body. You can appreciate the interventricular foramen here. You can see the pineal gland here, right? And this is the region of the midbrain, traversed by the cerebral aqueduct, fourth ventricle, pons. Now, what is the artery pointed out here? You see an artery running in close relation to the corpus callosum. What artery is this? Which cerebral artery is this? That's the anterior cerebral artery, right? In case you see an artery near the splenium, that will be the posterior cerebral artery. And remember, there is a important subarachnoid cistern. Behind the splenium, it's called the cisterna ambiens. Okay, what vein lies there? The important content over the cisterna ambiens is the great cerebral vein of Galen. Right? Great cerebral vein of Galen. Okay. So we have seen the mammillary body here. Here, this is the fornix. We have seen this picture, right? Fornix is here. And here again, another coronal section. You can identify the fornix here. Okay. So here, this is the pons. This is the medulla. Above the pons, this is the midbrain region. The pigmented gray matter that you see here is the substantia nigra. Okay. Yes, again, you can make out the lateral ventricle, septum pellucidum, and fornix. Do you see mammillary body here? Can I help you? So this is the thalamus. This will be the hypothalamus. And this is going to be the mammillary body. Can you identify the hippocampus here? That seahorse appearance. Okay. So you should be able to identify the fornix and mammillary body. Fornix is coming from the hippocampus, I told you. Mammillary body part of hypothalamus. Again, in the interpeduncular fossa, mammillary body. Okay. And you know, these all form the part of the Pappi circuit. From the mammillary body, the fiber is going to project to the anterior nucleus of thalamus. From that to cingulate gyrus, from the cingulate gyrus to entorhinal cortex, and again to hippocampus. Pappi circuit, I'm sure all of you must be thorough for emotional and memory, right? Recent memory. Okay. The few other nucleus that I want to discuss in thalamus is in the ventral tire, VPM, ventropostromedial. What are the afferents to the ventropostromedial? Coming from the face, carrying the sensation from the face, the trigeminothalamic, the taste sensation, solitariothalamic. What are the afferent to the ventropostrolateral? Ventropostrolateral nucleus is going to receive the lemnisci, LL, okay? Spinal lemniscus is bringing pain, temperature, touch from the rest of the body, right? Medial lemniscus is the continuation of the posterior column, right? So vibration, 2-point discrimination, all that. Okay. Thalamus is receiving all this. Where is it going to project to? From the VPM and VPL to the postcentral gyrus, 3, 1, and 2. Okay. And this VL is going to receive from cerebellum and project to 4 and primary motor cortex and premotor cortex. Okay. 4 and 6. The ventral anterior nucleus of the thalamus will receive from the globus pallidum. Excuse and project to premotor and frontal eye field. Okay, so these are all important connections which have been asked over the previous years and higher chance of being repeated. Okay, it's easy. This question you can do it with me. 65-year-old female presented with resting tremor. Yes, characteristically, yeah, it's going to point towards Parkinsonism. Intentional tremor, where do you get? In cerebellar lesions. I told you cerebellum is very important. Okay, please go through it. And Parkinsonism, the lesion is over the substantia nigra. What happens when there's lesion of caudate nucleus? What type? What is the name given to the involuntary movement when there's a lesion of caudate nucleus? Chorea, purposeless jerky movements of the face, tongue, and the limbs. Subthalamus will lead to balismus, hemibalismus. That here the proximal part of the limb, the girdle, pelvic girdle, shoulder girdle, all that is involved. And globus pallidum will lead to the production of involuntary movements, slow sinus movements of the extremities. It's called as the athetosis, right? You should be able to identify it also, isn't it? Yes. So here in the floor of the lateral ventricle, caudate nucleus, putamen, globus pallidus. This will be the subthalamic nucleus. The pigmented band will be the substantia nigra. Okay. Definitely you should be able to identify it, give its lesion. Yes. This case, it's easy. So the patient is presenting with ptosis, eyeball turned down and out, and pupil dilated. You have to just tell me which cranial nerve supplying the muscles of the eyeball is involved. Yeah. Ptosis. Yeah, it's very characteristic of which cranial nerve? 3, 4, 6. Pupil dilated ptosis. This is enough to clinch the diagnosis. Yeah, if you have answered correctly in the chat box, it's the oculomotor nerve. Now you have to just tell me aneurysm of which of the following arteries could have resulted in injury to the compression of the oculomotor nerve. So as far as arteries involved, arteries of the brain, right? Blood supply of the brain in upper limb axillary artery, head and neck subclavian artery, maxillary artery, and an abdomen internal iliac artery. All these have been repeated again and again. Make sure you go through it, okay? So here we'll identify the arteries. We are just going to identify the arteries in this image, okay? We're not complicating it. This is the internal carotid artery. It has a smaller terminal branch going in front, anterior cerebral artery. And this larger terminal branch, middle cerebral artery. And one going and joining the basilar artery termination, posterior cerebral artery. This is the posterior communicating artery. One more I will show you. This one going deeper, you can see. That's the anterior choroidal artery. Right? Now you can see the vertebral arteries here. The vertebral arteries. Yeah. The vertebral artery of both the side uniting to form the basilar artery. Right? So the important branches of the vertebral artery that you see here, this is the anterior spinal artery. Can you appreciate this branch here, this tortuous branch here? That's the posterior inferior cerebellar artery. Recent May INICET, they've asked it, right? Occlusion of posterior inferior cerebellar artery leads to which medullary syndrome? Yeah, the pica syndrome is also called as the lateral medullary syndrome or the Wallenberg syndrome. It's a branch from the vertebral artery. Okay, what are the branches from the basilar artery? This is the antero-inferior cerebellar artery. All these are the pontine branches, isn't it? Now, this basilar artery is going to give rise to the superior cerebellar artery, and the terminal branch is the posterior cerebral artery. Right? Now, between the posterior cerebral artery and superior cerebellar artery, can you make out these nerves? This is the third nerve. And this is the fourth nerve. Now see, the third nerve is closely, this I told you is the posterior communicating artery. This is the third nerve, right? So, posterior communicating artery will affect the nerve closely related to it. That's the oculomotor nerve. Now coming to the nerves of the brainstem, isn't it? So, this is the midbrain, this is pons, and this is the medulla, right? So in the recent INICET, they have asked this picture, right? Okay. So in the midbrain, this nerve that you see here is the third nerve, right? The third nerve, oculomotor nerve. And coming from behind to front, this is the trochlea nerve. This is the only cranial nerve that is going to exit from the dorsal aspect of the brainstem. Okay, the trochlea nerve. And over the pons, you can see the trigeminal nerve, right? The thickest of all the nerves. And at the pontomedullary junction, this was the one asked, sixth nerve, 7th nerve, and 8th nerve. And this was asked once. What is this you see here in the medulla on either side of the midline? Pyramid. What lies underneath the pyramid? Corticospinal fibers. So injury to the pyramid, what will happen? Contralateral hemiplegia. Right? Just lateral to the pyramid, we have the olive. What lies underneath the olive? Inferior olivary nucleus. This is the 9th, 10th, and the 11th cranial nerve. Between the pyramid and the olive, you'll get to see the 12th nerve. Okay, so these are all important image-based questions, which you should definitely know. So as you see here again, this is your olfactory nerve. This is the optic nerve. You can see how close the third nerve is related to the posterior communicating artery, also the posterior cerebral artery, isn't it? This is the 4th nerve, 5th nerve, 6, 7, 8, 9, 10, 11, and 12. Okay, so the arteries, the cranial nerves, relationship between the arteries and the cranial nerves, right? Again, this again cranial nerve, an important image related to the cranial nerve which has been asked. Okay, so here you can see this is the internal carotid artery. This internal carotid artery, it gives a branch which is going to enter the optic canal along with the optic nerve. Okay, so this is the optic canal where you see the optic nerve and the ophthalmic artery, which is a branch of internal carotid artery. Okay, this is the oculomotor nerve. This is the thinnest of all the cranial nerves, the trochlear nerve. You can see the 5th nerve here. This is the abducent nerve. And in the internal acoustic meatus, you can see the 7th and the 8th. This is the region of the jugular foramen where you get to see 9, 10, and 11. And once they've asked, right, the 9th nerve has a separate dural sheath. The 10th and 11th are enclosed within the same dural sheath. And below that, you'll see the 12th nerve, right? Okay, here, this was an image-based question asked. You see the boundaries of the orbit, roof, floor, lateral wall, medial wall. Understand, except the lateral wall, all the other boundaries is going to have two muscles, related to two muscles. The recti, okay? The recti are applied closer to the eyeball. So if you see here, this is the superior rectus, inferior rectus, medial rectus, lateral rectus. What you get to see below the inferior rectus, this is the inferior oblique. And in the medial wall, above the medial rectus, you get to see the superior oblique. Similarly, what is not shown here, this one here, above the superior rectus in the roof will be the levator palpebrae superioris, which is going to elevate your upper eyelid. Now, can you tell me in this image, what muscle the arrow is pointing at? Okay, appreciate it's on the medial wall, above the medial rectus. So it's going to be superior oblique, which is innervated by the trochlear nerve, right? Now again, this also has been asked over the previous years. So image A, B, and C. You're going to tell me which cranial nerve is injured here. So in the image A, okay, you can see this is the right eye, this is left eye. Okay, 1, 2, and 3. Okay, all 1, 2, and 3, you can see that there's inevitably drooping of the upper eyelid, what we call as ptosis. The muscle responsible for elevating the upper eyelid is levator palpebrae superioris, and that is innervated by oculomotor nerve. So ptosis is a feature of oculomotor nerve, right? And then you can remember it, PEDAL, features of third nerve injury. External strabismus due to injury to the medial rectus. Medial rectus is supposed to adduct. If it's paralyzed, the patient will not be able to adduct the eyeball as you see here, right? And D for dilated pupil, because the sphincter pupillae and loss of accommodation due to paralysis of ciliaris muscle. sphincter pupillae and ciliaris are supplied by the parasympathetic component of third nerve. Okay. And because most of the muscle is innervated by the third nerve, apparent proptosis. Okay. So ptosis, external strabismus, dilated pupil, and loss of accommodation are the cardinal features of oculomotor nerve injury. What do you see in image B? Right eye, left eye. You can see the right eye, the eyeball is turned upward and inward. Okay, the patient is not able to turn the eyeball down and out. Okay, so the patient will have difficulty while reading a newspaper or walking down the stairs. Diplopia is present while reading a newspaper or walking down. The muscle which helps you to look down and out is superior oblique, which is innervated by the fourth nerve. So image B is fourth nerve palsy. Coming to image C, right eye, left eye, 1, 2, and 3. See the last image 3. The right eye is adducting. The left eye is supposed to abduct, to see towards the left. The patient is having problem in abducting his left eye. So what is the muscle which causes abduction? Lateral rectus, that is innervated by the sixth cranial nerve. So image C is abducent nerve palsy, right? Again, coming to the foramens of the skull. Okay. So here again, I told you this is the optic canal, superior orbital fissure, but the one which has been frequently asked again and again. Here, I'll just zoom it in the middle cranial fossa. You can identify the foramen rotundum here, foramen ovale, and behind that foramen spinosum. What passes through foramen rotundum? A single structure, right? What is it? Maxillary nerve. What passes through foramen ovale? I'm sure, damn sure all of you will be knowing. Mandibular nerve, accessory meningeal artery, lesser petrosal nerve, emissary vein. And coming to this, what is this foramen? Oh, sorry, we'll do foramen ovale, spinosum. Foramen spinosum transmits the middle meningeal artery and nervus spinosus, isn't it? Okay. Now coming to this part, along the either side of the body of the sphenoid, that foramen you see here is the foramen lacerum. Remember the foramen lacerum, it's not going to transmit anything. It's going to be covered by a membrane in the living. But the posterior part of it receives the upper opening of the carotid canal, and anteriorly it's related to the pterygoid canal. Okay, you can see this is the greater wing of the sphenoid, petrous part of the temporal bone. This is the body of the sphenoid. So it lies at the junction of these three. This is the internal acoustic meatus transmitting the seventh and eighth nerve. Lower down, we have the jugular foramen. Okay. The middle compartment of which transmits the 9, 10, 11. Anterior compartment transmits the inferior petrosal sinus. Posterior compartment, internal jugular vein, which is continuation of the sigmoid sinus. The syndrome, a fracture of the base of the skull involving the jugular foramen, is called as the Burnett syndrome. Below that, hypoglossal canal. So all this has been asked repeatedly over the previous years. Right. Can you identify this bone? It is the sphenoid, isn't it? Yeah. So this is the lesser wing of sphenoid, greater wing of sphenoid, body of the sphenoid with the sphenoidal sinuses. And here, this is the medial pterygoid plate, lateral pterygoid plate. You're going to tell me what is A, what is B. You see two foramen, right? A and B. Okay, need not confuse, need not worry much. This foramen, which you see between the medial and lateral pterygoid plate, they will label it as pterygoid canal. Do you know what is its other name? Nerve of pterygoid canal, Vidian's nerve, right? So this is the Vidian's canal. And what is this opening that you see here? Any idea what could it be? It transmits the maxillary nerve from the middle cranial fossa to the pterygopalatine fossa. It's nothing but the foramen rotundum. Right? So this was also asked previously. And this, yeah. So this foramen was pointed out. You know, it's the mandible. It is the mandibular foramen. What is the structure that's going to pass through it? Inferior alveolar nerve and vessels. What is it a branch of? From the mandibular nerve. What muscle does it supply? Right? It's going to supply entire lower jaw, right? Gums of the lower jaw. It also supplies the two muscles, anterior belly of digastric and the mylohyoid. It gives the nerve to mylohyoid, which supplies mylohyoid and anterior belly of digastric. Do you know which is the nerve related behind the third molar tooth? The lingual nerve. Okay. And yeah, a few things that I want to discuss here. You can tell me. Injury to the right hypoglossal nerve. The tip of the tongue is going to deviate to the right or to the left. Yeah. Same side. Okay. So injury to the hypoglossal nerve. The tip of the tongue will deviate to the paralyzed side. Injury to the right vagus. The uvula will deviate to right side or left side. Injury to the vagus nerve, right vagus nerve, the uvula will deviate to the, yes, to the side which is normal. Okay, so please remember left side. Similarly, in facial nerve palsy, what is the difference between upper motor and lower motor neuron facial palsy? It's very easy. You know, there's a right and left cerebral hemisphere, right? The right hemisphere has control over the left side of the body, and the left hemisphere controls the right side of the body. So upper motor neuron lesion, if you imagine right side, okay, don't see this picture. The right upper motor neuron fibers are involved. The left side of the face is going to get involved, right? Left side. But what is the difference? The upper face is paired. Why? The upper part of the face is going to receive fibers from both the cortex, bicortical innervation. Okay. In lower motor neuron palsy, in right lower motor neuron palsy, what is happening? Normally, lower motor neuron is going to be ipsilateral and it involves the entire face, including the upper face. Okay. So, upper motor neuron, contralateral lower face. Lower motor neuron, ipsilateral, upper and lower face. Right? Yeah, this is again another important question. The red arrow is pointing to an important landmark over the lateral aspect of the skull. What is it called? Pterion, pterion, pterion. Everything about the pterion is important. As you see here, the pterion is present at the junction of four bones. What are they? Frontal, parietal, temporal, and what is this one? Greater wing of sphenoid, right? So what is the vessel that lies underneath the pterion? Is the middle meningeal artery. They didn't ask you that. Here they've asked, how does this vessel enter the cranial cavity? Through which foramen? The middle meningeal artery along with the nervus spinosum, it enters through the foramen spinosum. Rupture of the middle meningeal artery will lead to extradural hemorrhage, extradural hematoma, right? And another question, this middle meningeal artery is a branch of which artery? Maxillary artery. Branch of which part of the maxillary artery? From the first part. Okay, this maxillary artery. I've told you what are the arteries you should remember. Axillary, subclavian, maxillary artery, external carotid artery, internal iliac, and blood supply of brain. All this is very important, right? Okay, so there are around 15 branches from the maxillary artery. So easier way to remember is you can use this mnemonic. I'm not going to read it all, okay? First part, second part, and third part. Okay, so they've asked over the recent years, they've given a extended matching option. Yeah, you have to pick out what are the branches from the second part or the third part. And you should know middle meningeal artery, very important. Accessory meningeal artery, foramen spinosum. The sphenopalatine artery from the third part is called the artery of epistaxis. That Little's area, Kieselbach's fluxus, all that, okay? Middle meningeal artery we have seen. Now coming to another important image-based question. This is the subclavian vein. This is internal jugular vein. Okay, the blues are labeled. Now coming to the red. This is the subclavian artery. This is a common carotid artery. Now coming to the nerves, what are all the yellow you see here? Okay, before that, this is the scalenus anterior muscle. This is scalenus medius muscle. Excuse me. Now, in the interval between scalenus anterior and scalenus medius, you get to see the trunks of the brachial plexus. Upper trunk, middle trunk, lower trunk. Yes. Running anterior to scalenus anterior, this nerve is the phrenic nerve. And this nerve running between the internal jugular vein, common carotid artery within the carotid sheath, that is the vagus nerve, right? This is the trachea, this is esophagus. So in the tracheo-esophageal groove, this is the recurrent laryngeal nerve, right? And another thing behind the carotid sheath, yeah, this is the cervical part of the sympathetic trunk, right? So you should know the location of these nerves. Now, same thing, okay, but a cadaveric image. Again, A is going to be phrenic nerve. So this image was given and the question asked was, injury to which of the following structure will lead to paradoxical breathing? You know, phrenic nerve is the motor to the diaphragm, right, coming from the cervical plexus, okay? Injury to the phrenic nerve is going to cause avulsion of the phrenic nerve, yeah? Difficulty in breathing, yes. So B is again vagus. And yeah, C is the sympathetic trunk. Injury to the sympathetic trunk, again, Horner syndrome. D is the recurrent laryngeal nerve. Okay, the three nerves that I want to discuss with you, external laryngeal nerve, internal laryngeal nerve, recurrent laryngeal nerve. External laryngeal nerve is entirely motor. It supplies cricothyroid muscle and it accompanies the superior thyroid artery. So whenever you're going to try to ligating the superior thyroid artery, you accidentally injure the external laryngeal nerve. Cricothyroid, you know, is the tensor of the vocal cord. So injury to external laryngeal nerve, what is going to happen? Patient is going to have a difficulty whenever he tries to shout at someone, call someone louder. Okay, so the patient will present with a weak voice, right? Internal laryngeal nerve, on the other hand, it's entirely sensory. It supplies the mucosa of the larynx above the vocal cord. So injury to the internal laryngeal nerve will present, the patient is going to present with aspiration. Recurrent laryngeal nerve is motor and sensory. It supplies the mucosa of the larynx below the level of vocal cord. So injury to the recurrent laryngeal nerve is again aspiration. It supplies the safety muscle of larynx, the muscle which abducts your vocal cord. What is that? Posterior cricoarytenoid. So injury to the recurrent laryngeal nerve can lead to difficulty in breathing, not able to abduct the cord. And most of the muscles are going to be innervated by the recurrent laryngeal nerve and larynx. So it leads to hoarseness. Okay, so injury to these three nerves are very important. You should be able to identify it in an image also. Again, here another important image-based question. So this red color is the investing layer of the deep cervical fascia. This blue enclosing the thyroid gland is the pretracheal fascia of the deep cervical fascia. You can see the vertebra. This is the prevertebral layer of the deep cervical fascia. This green one that you see here is the buccopharyngeal fascia. Now this prevertebral will divide into an anterior layer and the posterior layer. I'll take my highlighter, I will zoom in. This space that you see between the anterior and the posterior layer of the prevertebral fascia, we call it as the danger space of neck, right? Okay, the scalp, we have the dangerous layer of the scalp, right? Similarly, a dangerous area of the face. And over the neck, we have the danger space of neck, okay? Dangerous space of neck between the two layers of the prevertebral fascia. Now, just anterior to it, here, between the buccopharyngeal fascia, I'll take a different, I'll use a pen. Between the buccopharyngeal fascia and the alar fascia, on either side of the midline, which are put as lines, that is the retropharyngeal space. Okay, it lies on either side of the midline. There are lymph nodes here. It can lead to abscess, retropharyngeal abscess, right? Now, in the same image, I want you to identify 5 nerves. Yes, we'll do it. You can see this is the, one second, this is the trachea. This is esophagus. So this nerve that you see in the tracheo-esophageal groove, this is going to be the recurrent laryngeal nerve. This is the carotid sheath with the artery medially and the vein laterally. And the nerve here is the vagus nerve. Behind the carotid sheath is again the cervical part of the sympathetic trunk. And here, this is the scalenus anterior muscle, scalenus medius muscle. I told you the nerve running anterior to scalenus anterior is the phrenic nerve. And this is scalenus medius, I told. So the trunk that you see between anterior and medius is going to be part of your brachial plexus. Done? Okay, so the 5 nerves and injury to it, what happens? Now, A, B, C, D, to show you the muscles of mastication. We'll come back to this question again, right? So this is the temporalis. That is it insert into the coronoid process of the mandible. Outer surface of the ramus of the mandible, we have the masseter. Once the ramus is removed, the muscle that you see on the inner surface of the ramus is medial pterygoid. This one going towards the capsule of the temporomandibular joint is the lateral pterygoid. Right? Now, all these muscles are going to be supplied by anterior division of the mandibular nerve, except the nerve to medial pterygoid, which comes from the trunk of the mandibular nerve. So this you should be able to remember, okay? And then of these 4 muscles, all of them are going to be elevators of the mandible and close the mouth, except lateral pterygoid is the only depressor of the mandible, which helps to open the mouth. We are talking about the muscles of mastication. Other than that, the suprahyoid muscles that you see, the mylohyoid, the geniohyoid, and the digastric, they will also pull the mandible down and open it. Okay. Now going back to the image, where is the mandible here? This is the mandible. So this muscle sitting on the outer surface of the ramus of the mandible, we are going to label it as masseter. This muscle coming from up and inserting into the coronoid process is going to be temporalis. And this muscle going towards the capsule of TM joint is going to be lateral pterygoid. Inner to it will be the medial pterygoid, right? Now they ask which one helps in opening of the jaw. Obviously, it's the lateral pterygoid, okay? The temporalis is a powerful retractor. Masseter, it's a powerful like protraction and elevation. Lateral pterygoid and medial pterygoid of both the sides, when they contract simultaneously, it causes protrusion and alternate contraction, side to side chewing movements. Right? So this was asked in INICET May, 2023. Mandibular nerve, just now we saw chewing. Glossopharyngeal nerve, taste from the posterior 1/3 and circumvallate papillae. And facial nerve, chorda tympani branch, anterior 2/3 of the tongue. What are the 2 muscles innervated by the spinal accessory? Sternocleidomastoid and trapezius. Okay, this trapezius, it helps in overhead abduction of the arm. You want to comb the hair, you want to paint the roof, okay, and shrug the shoulders. It's all because of trapezius. So injury to the spinal accessory nerve, the patient will not be able to elevate his shoulders, and that condition, it goes by a name, shoulder drop. Spinal accessory nerve, you can see it over the posterior triangle, upper part of the posterior triangle. It is also a content of the carotid triangle, okay? So injury to the spinal accessory nerve will paralyze 2 muscles, sternocleidomastoid and trapezius. Trapezius, you need to elevate the shoulder. Injury can lead to shoulder drop. Now, coming to this, upper limb peripheral nerve injuries are very important, right? So what you see here is a picture of the humerus with A, B, C, D. They have given patient unable to flex the interphalangeal joint of the ring finger, little finger. That even clinches the diagnosis towards ulnar nerve. If it is middle finger and index finger, it's the median nerve. Some different nerves are there, right? And what is the nerve related to the surgical neck of humerus? Axillary nerve. The nerve that runs in the spiral groove on the posterior surface of the shaft of the humerus, radial nerve. So here is the trochlea. Above the trochlea is the medial epicondyle. The nerve running behind it is the ulnar nerve. Okay, B here is the capitulum. And above the condyles, okay, the supracondylar fracture can involve the median nerve and brachial artery, right? Okay, so here what is told, not able to hold a card. You're not able to bring the fingers close together. You're not able to adduct. Adduction of the fingers is the action of the palmar interossei pad, right? And all these interossei, palmar interossei and the dorsal interossei, all of them are going to be innervated by the ulnar nerve, right? So over the years, they have asked repeatedly about something related to the lumbricals, ulnar nerve, claw hand, all that, right? So here this image is pointing towards the lumbrical. Which lumbrical? There are four, right? 1 and 2 are unipinnate and innervated by the median nerve. 3 and 4 are bipinnate and innervated by the ulnar nerve. So this one close to the thumb is first lumbrical, innervated by the median nerve. Action of lumbrical, you'll be knowing, right? Flexion of the metacarpophalangeal joint and extension of the interphalangeal joint, inverted L. Reversal of that goes for clawing. Again, this, I told you little finger and ring finger always towards the ulnar nerve, right? Clawing. Klumpke's paralysis involves the lower trunk, median nerve and ulnar nerve, yeah, typically leading to claw hand. Horner syndrome is due to involvement of sympathetic fibers, yeah, but typically characteristically Klumpke's paralysis is claw hand. Yes, here this is to show the book test. We have seen card test. This is the book test. The patient is trying to hold the book by adduction of his thumb. Adductions of the digits we saw palmar interossei. Adduction of the thumb is by this muscle, adductor pollicis. What is the nerve supply to this adductor pollicis? Ulnar nerve, right? So this is the right thumb, this is left thumb. As you see here, the patient is not, which thumb is normal here? The left is normal, okay? The right thumb is flexed. So the patient is not able to adduct the right thumb, but instead flexes his right thumb to hold the book. This flexion, yeah, is called as the Frohman sign. Done? Right, so this we have already seen. This is the Igawa test. You're trying to move the middle finger on either side to test for the dorsal interossei. Inability to keep the little finger adducted is called as the Wartenberg sign. Yeah, all of them related to ulnar nerve injury. And these are all images to show you median nerve injury. Yeah, we're just going to tell the name and the muscle paralyzed. So this is the hand of benediction, inability to flex the, yes, which digits? The middle finger and the index finger. Here it's the Oshner's clasp test, right? Presenting with the pointing index of the which digit? Index finger. Again, flexor digitorum profundus tendon. This they've asked frequently. The pen test. You're testing the abductor pollicis brevis muscle. This is the eighth thumb. The muscle paralyzes the opponent's pollicis. You can see the median claw, right? Paralysis of the first and second lumbrical. This is the OK sign, yeah, seen in anterior interosseous nerve. Like if the anterior introitious nerve is intact, you can perfectly make a OK by flexing the distal phalanx of the thumb and the index finger. Because the flexor pollicis longus, which bends the thumb, and the flexor digitorum profundus that bends the index finger is going to be innervated by anterior introitious nerve. In anterior introitious nerve injury, this cannot be done, right? Yes, again, cubital fossa, they keep asking repeatedly. And A, B, C, and D. What are this? C is a muscle, you see here, right? This is the biceps tendon. And B is the artery, right? The brachial artery. A is going to be median nerve. And D is going to be radial nerve. What do you get to see in this image? The patient, yeah, that is his left hand, right? He's not able to dorsiflex the left hand. It's called as the wrist rock. That happens in the injury of the radial nerve. Inability to dorsiflex, inability to extend, right? Again, axillary nerve injury, surgical neck of humerus fracture. It's going to supply the deltoid, which is an abductor. It supplies the teres minor, which is a lateral rotator of the shoulder. And it gives one cutaneous branch. Can you tell me? The upper lateral cutaneous nerve of arm. Okay, so that is what you're testing here. It's called the regimental badge of anesthesia. Loss of sensation over that upper lateral part of the arm. Okay, so the rounded contour of the deltoid is gone. The rounded contour of the shoulder is gone. And this, yeah, this shoulder is going to be sort of square or pointed out. Okay, axillary nerve injury. And again, cutaneous innervation of the hand, the dorsum of the foot are really very important. As you see here, the 1.5 digits on the medial aspect, both on the palmar and dorsal aspect is by ulnar nerve. Whereas the lateral 3.5 on the palmar is by median nerve, on the dorsal is by radial nerve. But appreciate the skin over the distal phalanx 3.5 dorsal is by median nerve, right? So you can get a case scenario where a particular nerve can be injured, muscle paralyzed, patient presenting with some deformity, some test positive, and they would be given one clue like sensation lost over. Yes? Again, in lower limb, the pointed structure is the fibula, the neck of the fibula. The common peroneal nerve winds around it. So this common peroneal nerve is going to divide into superficial peroneal nerve and deep peroneal nerve. The deep peroneal nerve it supplies the muscles of the front of leg. What does the muscle of the front of the leg do? They try to elevate your foot, right? It's called the dorsiflexion. The dorsiflexion of the ankle. So all these muscles in the front of leg are innervated by the deep peroneal nerve. So fracture neck of the fibula, injury to the deep peroneal nerve, patient will not be able to dorsiflex his foot. And what happens to the foot? It goes for a drop, foot drop. Injury to deep peroneal nerve, foot drop. The other important topic is also knee joint, the O'Donnell triad, all that, okay? And of course, the Trendelenburg gait we'll be doing now. And A, B, C, D again, right? So this area over the medial surface of the ankle is going to be innervated by the saphenous nerve, which is a branch coming from the femoral nerve. And remember, this nerve is closely related to the great saphenous vein. Great saphenous vein, we can use it as a graft, and when do a lot of procedures, open up, cut down procedures are done, right? So it can injure this saphenous nerve, which is running anterior to it in this area. So the patient can present with loss of sensation over this area if this nerve is injured. And this first interdigital cleft is innervated by the deep peroneal nerve. So you can get a case scenario patient presenting with foot drop and loss of sensation over the first interdigital cleft. You should be able to take it as a clue. And the majority of the dorsum of the foot, as you see here, C, is innervated by the superficial peroneal nerve. And along the lateral border of the foot is going to be innervated by the sural nerve, which is a branch of tibial nerve, right? Yeah, Trendelenburg sign, Trendelenburg gait, the superior gluteal nerve, the gluteus medius minimus muscle are all very, 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 very important. The question has been put in different forms, but invariably appears in every paper, right? So what is this Trendelenburg's gait? So this is your left leg, this is the right leg. When the left leg is lifted off the ground, there's a tendency for the left pelvis to sink, but it's prevented. The pelvis is prevented from sagging down by the contraction of the muscles of the opposite side, the gluteus medius and the minimus muscle. Okay, so you know there are three gluteus muscle, right? Gluteus maximus, gluteus medius, gluteus minimus, right? Remember the gluteus maximus, its main action will be extension at the hip joint. It's a chief lateral rotator of the hip, and some of the upper part of the fibers is going to cause abduction of the hip joint, right? Coming to medius and minimus, along with one more muscle called the tensor fascia lata. They are the abductors and medial rotators of the hip, right? Gluteus maximus is innervated by inferior gluteal nerve, whereas medius minimus tensor fascia lata, and recently they have included the piriformis in the recent edition of Grace. These four muscles are going to be innervated by the superior gluteal nerve, right? Okay, so maximus, inferior gluteal nerve, medius and minimus along with tensor fascia lata and piriformis, superior gluteal nerve. Maximus is a lateral rotator. Medius, minimus, and tensor fascia lata are medial rotator. Piriformis is again a lateral rotator, right? So if the patient pelvis sinks on the left side, which gluteal nerve is injured? The right side superior gluteal nerve. What are the muscles paralyzed? The right gluteus medius, gluteus minimus are paralyzed. Okay. So again, you can identify it in the image. This is the gluteus maximus. This is the gluteal upper neurosis under which lies the medius, into which you put the intramuscular injection. So if you remove the medius, you'll get to see the gluteus minimus. And below that is the piriformis. Okay, so this picture, this is the piriformis. The nerve you see above the piriformis is the superior gluteal nerve that supplies the gluteus medius and gluteus minimus. This nerve that you see below the piriformis is the inferior gluteal nerve that's going to supply the gluteus maximus, right? And once they've asked about the attachments of these muscles, so what do you see here? The femur. What is B? Lesser trochanter. A is greater trochanter. What muscle is inserting into the lesser trochanter? Iliopsoas. Into the anterior surface of the greater trochanter is gluteus minimus. Into the lateral surface of the greater trochanter will be gluteus medius. This D is the gluteal tuberosity, which receives 1/4 of the fibers of gluteus maximus. 3/4 of the fibers of gluteus maximus, they go for insertion into the iliotibial tract. Okay, so everything about this topic, whatever each word that has come out from my mouth has been asked over the previous years. Okay, make sure you're thorough in this topic. Now, marked areas related to which of the following? What you see here is the left kidney. Okay, the hilum of the left kidney will be related to the tail of the pancreas. Over here will be related the spleen. And here will be the stomach. And to the upper pole will be related the suprarenal. Here will be the splenic flexure. Here you'll get to see the coils of jejunum. Okay. So the marked areas related to the spleen, right? The anterior relations of the right kidney is also equally important. Hilum of the right kidney will be related to the second part of duodenum. And they've also previously they asked about the relation of the duodenum, the third part of the duodenum. You can see it's anterior related to the superior mesenteric artery, superior mesenteric vein in the root of the mesentery. What is the vertebral level of origin of the superior mesenteric artery? L1. Okay. So this syndrome, okay, you have the abdominal aorta, the superior mesentery originating from it. This junction between the origin of superior mesenteric artery and the abdominal aorta, you get to see three structures sandwiched between the superior mesenteric artery and abdominal aorta: the left renal vein, the uncinate process of pancreas, and the third part of duodenum. Sometimes when this angle is getting reduced, it can compress these structures and it goes by a name, Wilkie's syndrome or the nutcracker syndrome, right? So the anterior relations of the third part of duodenum are important, right? Okay. Now coming to this, another favorite topic, the urethra, the male urethra. So this is the prostatic urethra. This is membranous urethra. What you see here, this is the bulbar urethra, the penile or the spongy urethra. Remember that this prostatic urethra, membranous urethra are posterior. Rupture of the membrane, that's the most fixed part, right? So the membranous urethra ruptures easily. The rupture of the membranous urethra, the urine will collect, yeah, in the deep perineal pouch and in the space around the prostate and bladder. Yeah. Whereas the rupture of the bulbar and the penile urethra, the urine is going to collect in the superficial perineal pouch, around the scrotum, around the penis, and it can also extend into the lower part of the anterior abdominal wall. Okay, so this is the main difference. Membranous urethra, deep perineal pouch. Bulbar urethra, penile urethra, superficial perineal pouch, around the scrotum, around the penis, and the lower anterior abdominal wall because of the continuity of the fascia, right? The Kohili's fascia. One second. The Kohili's fascia, as you see here, is going to attach to the deeper aspect of the urogenital diaphragm. So the communication between the deep perineal pouch and the superficial perineal pouch is lost, right? Again, the hilum of the lung. Okay, this is the right lung. The anterior-most structure in the hilum of the right lung is the superior pulmonary vein. Okay, and just behind that, you'll get to see the pulmonary artery. The bronchus is the posterior-most structure. This will be the eparterial bronchus above the pulmonary artery. This is hyparterial bronchus. This is supposed to be the pulmonary ligament. Just above the pulmonary ligament, you'll get to see the inferior pulmonary vein. I'll repeat it again. The anterior-most structure in both the right lung and left lung is the superior pulmonary vein. The posterior-most structure is the bronchus. Between the bronchus and the pulmonary vein, we have the pulmonary artery. Okay, and the lowermost structure is the inferior pulmonary vein. What is the difference in the hilum of the left lung is that there's one bronchus. No, it's not called as the eparterial or hyparterial. Superior pulmonary vein, pulmonary artery, and the bronchus. Simple, right? Yeah, this is again a very important topic, the neural crystals. So here in this image, what you see here is the notochord. What are the remnants of the notochord? Two structures, nucleus pulposus of the intervertebral disc and the apical ligament of dens. Just above this, this is the neural tube, right? And the yellow arrows pointing at the neural crystals. Either side of the midline neural tube is get to see the paraxial mesoderm. This is intermediate mesoderm, the lateral plate mesoderm. So what are the derivatives of the neural crystals? Of course, conotruncal septum, melanocytes, whatever ganglia you see, you can take it off, Schwann cells. Okay, the adrenal cortex is developing from the intermediate mesoderm. The amyloblasts, they all come from the ectoderm. So easier way to remember the neural crystals, which is a very frequently asked topic. Remember this, okay? Heart. What are the structures that arise from the neural crystals? that are going to contribute to the development of the heart, if you see, the conotruncal septum, the atrioventricular valves, and the semilunar valves, right? And cells, the cells, that is what I put here, POEMS, poems. The parafollicular cells or the C cells of the thyroid gland, right? The odontoblast, right? The enterochromaffin cells, right? And I would like to put two things. One is the melanocytes or the melanoblast, and then adrenal medulla. And lastly, Schwann cells. So H is done, C is done, coming to ganglia. What are the ganglia we can include? Yes, the parasympathetic ganglia, including the parasympathetic ganglia of the head and neck, right? Aortic ganglia, ciliary ganglia, pterygopalatine ganglia, submandibular ganglia. The parasympathetic ganglia that you see in the wall of the GIT, Meissner's ganglia, Meissner's plexus, Orbach's plexus. The sympathetic ganglia, right? And then, the dorsal root ganglia, the cranial nerve ganglia, trigeminal ganglia, all that. Okay, so these are all the derivatives of neural crest. Okay, so with this, I will wind up my session. And yes, what are the other things that I would like to discuss with you? Would like kindly go through the histology part. Okay, the lymphatic system, thymus, all that. And they have put an image of the respiratory epithelium before. So where do you find the cilia, stereocilia, all that? And sebaceous gland in the skin was asked to identify. So these are all very important. And embryology, the other things that are very important are the pharyngeal nerves we saw, pharyngeal pouch derivatives, the arch arteries. And general anatomy, make sure you cover the joints, which have been asked frequently. Okay, guys? So we can revise anatomy, like entire thing. It takes a time constraint is the main thing. Hope the session was very useful and all the very best. Okay, so after the exams, we'll do a recall also. Okay, so remember your time management is going to be very important. Yes, you won't be having time to go back and recheck your answers. Yes, all the very best. Definitely you can make it. Thanks, Raghu, for the opportunity.
Thank you, ma'am. Thank you so much. It was really a wonderful session, like recalling all the topics. And we have also done a last time during the November 2022 also a similar video was done. And similarly in the May also we done. So you can just go through those videos also so that it will be giving you a recall of all those questions which are left out here and the additional questions which are discussed here, or you can also concentrate on that. Thank you, ma'am. Thank you so much for joining with us today in spite of your tough schedule. Thank you so much, ma'am. And I wish everyone all the best and thank you.